What is obstetric medicine? Obstetric medicine, also known as maternal medicine, high risk of pregnancy, medical complication in pregnancy. It's basically dealing with pre-existing or newly discovered medical illness in pregnancy. And any patient, pregnant ladies who present with any of the 11 subspecialties in internal medicine that has occurred in the reproductive age. And that's basically include all the subspecialty. And in 2013, obstetric medicine has been added to the specialty under medicine. So let me take you over the worldwide centers in obstetric medicine. There are not many wide centers around the world, mainly in North America, Australia, New Zealand, South Africa, and Europe, and in the Middle East. So in North America, we have Wishan Chan, where I did my fellowship with her. She's in Vancouver now. And then in Toronto, there is Corinne Giddon, who established the mother risk for dealing with pregnant lady who wanted to know the efficacy of drugs in pregnancy and lactation. And also in North America, we have Raymond Bowery and Matthew Sermer, who is an obstetrician. In Europe, Catherine Nielsen-Percy is the godmother of obstetric medicine. She was one of the first who established this. And then coming to the Middle East, we have a center in Abu Dhabi, UAE, and I'm proudly presenting Kuwait, where I was appointed as a program director for the first international fellowship program in this field. So just a brief history of obstetric medicine here in Kuwait. In 2012, we established the fellowship program, and as you can see through the dates here, from 2012, we've been growing slowly and covering Amiri Hospital at the beginning, then started Amiri and Farwaniya, and in 2003, I'm happy to announce that we're covering now 4 major government hospitals, Amiri, Sabah Maternity, Farwaniya, and Jahra Hospital. So now to the main topic, which is cardiac updates. We don't really have much of updates in obstetric medicine. Our updates usually takes 5 to 10 years on average, and this is basically because we cannot perform a proper RCTs in this population, because it's always ethical not to give certain treatment for these patients. And we always say that the pregnancy is basically the stress test of life for women. And I'm not gonna go over the stress test for a group of cardiologists here, but basically the pregnancy is basically why we call it the stress test of life, because it tests the cardiac capacity and functionality throughout the period of a pregnancy. And this is by increasing the heart rate and cardiac output. So I'm just gonna go over some normal physiological adaptation in pregnancy. Understanding these changes help us determine whether the pregnant lady, whatever she has symptoms, is this normal or abnormal adaptation or complaints during her pregnancy. So normally there would be increase in cardiac output, increase in the heart rate, there is a decrease in systemic vascular resistance, and blood pressure, there would be a lot of variation. So this graph is basically, okay, so I would like you to pay attention to where is the 40, that's basically that term, or the third trimester, and that's basically when major events happen during a pregnancy. And if you can see, the first graph is the heart rate, and always the heart rate continue to rise, and stroke volume with the heart rate rise. But the cardiac output increases in the first trimester, reaches up to 50%, but in the period of labor, which is where major events happens, it increases up to 80%. Knowing, understanding these changes help us understand why some patients go into trouble in the immediate postpartum period. So what happens in during period, there is during labor, is that there is a 15% increase in the cardiac output, and because of the autotransfusion that occurs after delivery and after the getting the placenta out of the uterus and the contractility of the uterus, this would put the patient for a risk of developing pulmonary edema, and that's why the obstetrician needs to understand as well that being cautious with IV fluid in these patients, especially those patients with underlying cardiac disease. So all these changes that I'm discussing are normal in a pregnancy. So if you have a fragile heart to begin with, then that basically put the patient at higher risk. So you can see here in this graph what happens during contraction. This is during labor, and in the immediate postpartum period, that's when all the trouble happens. The blood pressure usually happens, what happens for the changes in the blood pressure is that at the beginning of a pregnancy, it will be stayed the same. In the second trimester, the systolic blood pressure and diastolic start to drop, and then start to get to pre-pregnancy level in the third trimester. And this drop in the second trimester helps explain this common phenomena or syndrome that occurs, which is supine hypotensive syndrome, mainly occurring in the second trimester. And that's when the patient presents to the emergency department or report to their obstetrician or physician that I'm feeling dizzy and I have dizzy spells, and sometimes these symptoms warrant further investigation. And this is basically because of the gravid uterus compressing on the IVC and reducing the blood pressure, even though it's for a few seconds, but it's severe enough to cause symptoms for the patient. So all these changes that I mentioned put a stress on the heart, and that's basically, I always tell the pregnant ladies, it's like you're running on the treadmill for the whole 9 months, and that's basically the effect of a pregnancy in normal, healthy woman. So what is normal and what is abnormal in a pregnancy? It is normal to have a tachycardia and pounding pulse. There is always a soft ejection flow murmur. There will be S3 gallop, ECG changes with left axis deviation, Q3 and lead Q3 and T3, and there will be ankle edema. What is abnormal, and warrant and needs further investigation, is a raised JVB. This is not normal. S4 and diastolic murmur, always abnormal, and they're always pathological, and you always need to investigate for that, as well as pansystolic murmur. So pregnant ladies usually come with symptoms. They don't refer them to us with a diagnosis. So it's our job to not just exclude major causes, but we have to find a diagnosis for these patients. And usually they present with, or the referral would be because of dyspnea and breathlessness. And if you remember the title that I put in the first slide, not that lecture is gold, because not all pregnant lady presenting with shortness of breath is pulmonary embolism. You have to look for other causes, and sometimes it's just a normal exaggeration of normal physiological adaptation with palpitation. The commonest presentation is palpitation, chest pain or chest tightness, and dizziness. These are the most common presentation that pregnant lady present to us. So how do we assess their cardiac risk during a pregnancy? Ideally, which almost never happens, even though I have to say in the last few months we've been getting this, is to have a pre-pregnancy counseling. And nowadays, actually, we're promoting and we're getting more patients with underlying chronic medical illnesses coming to seek medical advice before they get pregnant. We assess their cardiac function, what's the capacity of the heart, and LV function and valve status. That's if we know that they have cardiac problems. And I'm sorry for the busy slide, but this is the modified WHO cardiac risk assessment for cardiac patients who are seeking a pregnancy. What you need to know is that where I underlined the red is that their risk for having cardiovascular events from class 1 to class 4. And basically class 1 is that when you have the mild disease like small congenital ASD or VSD, mild prolapse valves or mild stenotic valves, or probably occasional ectopics. And then a class 4 is where you have those probably condition where we would recommend termination of a pregnancy. So how do we approach patient with cardiac problems during pregnancy? It's very easy to deal with any medical problems to divide them into pregnancy-related and non-pregnancy-related. Pregnancy-related include the tachycardia, peripartum cardiomyopathy, hypertension and preeclampsia, and benign systolic murmurs. The non-pregnancy is everything that is mentioned in the previous lecture, including ischemic heart disease, different kind of cardiomyopathies, and those on red is the one that I'm gonna touch point on them because basically dealing with these topics is very extensive. So sinus tachycardia is probably the commonest referrals we get in our clinics. Usually they present with palpitation, dizziness, and when it's bad enough, it will be associated with dyspnea. It's usually worsened as they advances in the pregnancy and they reach term, and not necessarily pulmonary embolism nor thyrotoxicosis. And please don't do thyroid function tests in the first trimester. It's always gonna be abnormal. And we still need to exclude other causes like pre-existing hyperthyroid, severe anemia, or structural heart disease. And we usually start a treatment when the palpitation is symptomatic or severe enough that is affecting the mother's daily activity. The second common referrals is the preeclampsia or gestational hypertension. Hypertension is well known from ages. It's one of the risk factors that predict future cardiovascular disease. And women having preeclampsia, that basically puts her even at a higher risk compared to those who did not have a preeclampsia. It affects 2 to 7% of a pregnancy worldwide, still unpredictable course of a preeclampsia. So not all preeclamptic patient that we come across is the same as the previous one. And even in the same patient with 2 preeclampsias, never the same. It varies from mild to severe catastrophic leading to death, and 20% of them develop hypertension subsequent to pregnancy, and 16% will have recurrent preeclampsia in other pregnancy. This slide is from a presentation I did in 2014, and as you see in the last sentence that preeclampsia might predict a future risk of cardiovascular event, and this is basically what's happening now. So there are cardiovascular risk unique to women. These are related to gynae or obstetric, include the menarche, menopause, and the last point you see the pregnancy complication. Pregnancy complication include preeclampsia or gestational hypertension, GDM, or gestational diabetes, recurrent pregnancy losses, or preterm labor. So study was done in 2005 by Joel Ray, and it's the CHAMP study where he did a retrospective cohort study of more than 1 million women who supposedly free of any cardiac disease. And they wanted to see whether maternal placental syndrome can affect or can predict any cardiovascular event for the future for these women. And their endpoint was any cardiac event occurring 90 days after delivery, which include either coronary events or cerebrovascular events or peripheral vascular disease. And what they found that of the 1 million, there was 7% with maternal placental syndrome, and in these 7%, 500 in a million had coronary vascular disease or cardiovascular events, compared to only 200 those without the MPS. And the risk was higher if there was associated fetal distress or fetal compromise. And so their recommendation was these women should have their blood pressure checked every 6 months from the incidence of or from delivery, and they should be encouraged for a healthy lifestyle and modify other risk factors. After that, Selim Youssef and Jason Dubrov did a retrospective or systematic review and meta-analysis for all women who've been diagnosed or established a diagnosis of preeclampsia, eclampsia, and they showed that the risk is basically doubled for early cardiac event or cerebrovascular event in these patients who have the diagnosis of preeclampsia or gestational hypertension. But they recommended that further research is needed. After these, the AHA put the statement in 2015 that the preeclampsia is strongly predict the premature cardiovascular disease in women. And if the pre-existing hypertension, which is hypertension before 20 weeks of gestation, was associated with a preterm delivery, then the risk is increased, or preeclampsia or hypertension with superimposed preeclampsia, again, the risk is increased. If you have two factors associated with the hypertension, then the risk is even higher. Then there was a study done by a group in the ACOG, American College of Obstetrics and Gynecology, where they had 80 women, 40 with preeclampsia and 40 without. And what they wanted to know whether if they wanted to follow these patients and do a CT coronary for them to see if there are any calcification in those patients with history of a preeclampsia. So that was the first prospective study to follow patients with the preeclampsia. And what they found that there was an increased risk of coronary artery disease in patients with history of a preeclampsia. And what the recommendation was is that these patients should be followed regularly and modify other risk factors to prevent premature cardiovascular events. And the risk is higher with the preeclampsia rather than pregnancy-induced hypertension. And if a pre-existing hypertension was already diagnosed, then there is also further increase in the risk. So cardiovascular disease is the leading cause of death in women and still remains the same. And some cardiovascular risk factors are unmodifiable or unadjustable. And history of preeclampsia should warrant close follow-up and modifiable of other risk factors associated. I'm going to discuss some of the cases that are not old. Actually, one of the two patients I'm going to present are still following them. 36 years old, this is her second pregnancy. She was referred to us, she was 18 weeks, with evaluation of her current pregnancy with history of peripartum cardiomyopathy in 2021. When we first saw the patient and took more history, she actually has dilated cardiomyopathy. It's not a peripartum cardiomyopathy since childhood, and she's been followed by pediatric cardiologists, then adult cardiologists. But the patient lost follow-up for more than 5 years ago. And her recent echo in December of 2022, her ejection fraction was 30 to 35%. She basically stopped all her medication for a few years, so she was having annual echo done in a private hospital. I'm gonna skip, I'm not gonna ask the audience just for the sake of time, but basically this patient, if we go with the modified WHO, she would be on the class 2 to 3 risk for cardiovascular event. So when they referred the patient was whether she needs to terminate the pregnancy or not. After we saw the patient, she actually looked very well. She was asymptomatic. Even her pregnancy, the previous pregnancy, she was off medication, and it wasn't really clear whether what she had postpartum is changes that can occur with the preeclampsia, because she was delivered because of shortness of breath and high blood pressure preeclampsia, and then when they did the echo, they found a low EF, which reverted to not normal, but slightly impaired. So we decided to start her on aspirin. She was already on Concor. We added low molecular weight heparin, and we wanted to do a follow-up echo. She remains asymptomatic. Her ejection fraction is 40%. We explain all the possible risk, and probably she will not make it to term, and she understands everything, but she looks very well, and she understands her risk. So the message here is that we need to continue medication, we need to optimize. We would prefer if this patient was seen prior to getting pregnant, but again, this is an ideal situation, and not necessarily we have it every time we see these patients. Most of the time, we have the patient already pregnant, and we just try to do whatever we can to help them go through the pregnancy. So what is new in the pre-existing dilated cardiomyopathy? If there is a mild LV impairment with a good functional status, it's usually low to moderate. Most of the patient will tolerate the pregnancy well, and we need to adjust the treatment, maybe add medication, diuretics if they need to. And it's very important to continue with the beta blocker. ACE inhibitor and ARBs are definitely a go after delivery. We still cannot give ARBs and ACE inhibitor during a pregnancy. And not to forget the thromboprophylaxis, especially if the EF is below 35%, and not necessarily they are indicated for cesarean section. They can
Dr.
still
Enas,
go under normal.
Sorry to interrupt. We have 1 minute, please.
Sure.
We're a little bit late. Thank you.
Case 2, this is actually the last one. 28 years old lady who was referred for evaluation of pulmonary hypertension, diagnosed when she was 18 years old. Her echo had normal EF, but her pulmonary pressure was 85%. So this is her third trial. She doesn't have a living baby. And basically, this is a clear, straightforward termination of a pregnancy. There is no other option that we can offer for this patient. And she's on Viagra, sildenafil, Flolan, Fusion Pump, Clexane, and Concor, and diuretics. She's not on oxygen therapy. So we had a meeting with her and with her husband, but they refused strongly to terminate the pregnancy. We could not force them, and basically we just have to do whatever we can to help her throughout. She did almost very well until she was 29 weeks, where she got admitted because of breathlessness, feeling tired, and she was admitted to maternity hospital, and then she was shifted to Jaber because of proper ICU setting and possible need for ECMO. They did an elective C-section. She was doing well, but unfortunately she developed sepsis, and that's basically what we talk about. These patients usually are immune compromised. Their cardiac capacity is not really well tolerated, especially in the immediate postpartum period, regardless of the mode of delivery, whether it's a C-section or normal vaginal delivery. So she remains intubated, and she did not require ECMO, but she was on ionotropes, still ventilated, and still they cannot wean her off the ventilator until 2 days ago. And the baby, again, has a premature complication with necrotizing colitis. So there is nothing new in the pulmonary hypertension. It's probably the only and the one thing that we advise against the pregnancy. All other medical chronic illnesses, maybe we can get around it, but pulmonary hypertension is always we always advise against pregnancy. So the take-home message, cardiac assessment should be done ideally pre-pregnancy. Some cardiac risk factors are unique to women and unadjustable. Most cardiac medications are safe to use in a pregnancy and lactation. Multidisciplinary team should care for a pregnant woman with cardiac history. And always think, whenever you come across this patient, what would you do if this patient was a man? And I'd like to, since this is March, I call it Women's Month, I'd like to congratulate all the women because Mother's Day is coming, and we just passed the International Women's Day. Thank you.
Thank you, Dr. Enas. Very nice presentation.